A very good evening to all of you. I am Rohan Devras, Senior Brand Manager, Ranbaxy CV Care. On behalf of Ranbaxy CV Care, I welcome all of you to today's symposia, Advances in Hypertension 2011. Ranbaxy CV Care is a diabeto-cardio division of Ranbaxy, which has brought a lot of blockbusters like Volix and Olvans. We have been in forefront in bringing numerous scientific initiatives like the one which we are conducting today. Now I request our medical advisor, Mr. Atul, to carry the session forward.
Good evening to all. To begin with, I'll request Ms. Namrata to do the floral welcome of Dr. Shinde. I would request Mr. Mahesh to do the floral welcome to Dr. Brian Tomlinson. And would request Mr. Srihari to please welcome Dr. Agarwal. It's our privilege and honor to welcome Honorable Chairperson for today's symposium, Advances in Hypertension 2011, Dr. Suresh Shinde. Dr. Suresh Shinde is the consulting physician and practicing since last 35 years. He is attached to Pune Hospital and Ruby Hall Clinic, interested in CMEs, computers and clinical research. Has published numerous papers in his name in many national and international journals. He is referee to the British Journal of Hematology. I would request Dr. Shinde to please take the proceeding forward.
Thank you, Dr. Gupte. It is already late. I really appreciate all the physicians who have come here after having a very hard, hectic day. One doesn't like to again come over and listen to some academic talk. If it has been Sunday morning, then it's a different story. But on a working day, it becomes really difficult, and I really understand it is already late. So I'll try to be very brief. The task that is given to me is just to introduce this topic of today. I will speak only for a few minutes through few slides. Cardiorenal continuum and olmesartan. The approach to CV disease, cardiovascular disease prevention is basically the lipid modification, lifestyle intervention, BP lowering, glucose lowering, that really forms the crux of the CV risk reduction. We all know, I am just trying to sort of refresh your physiology a bit so that we are better prepared to listen to the next speakers. The risk factors that we know: age, gender, smoking, inactivity, obesity, cholesterol, blood pressure, glucose, and an interplay of genetic factors. So all these, the risk factors and genetic factors, they completely interplay and give rise to the disease process. Increase oxidative stress, decrease endothelial function, the changes in the function, alterations in the structure, and then the clinical sequelae like myocardial infarction, diabetes, hypertension, obesity, so on and so forth. We all know that the pleiotropic effects of blood pressure lowering is the agents, is the ARBs and the ACE inhibitors on one side and the calcium channel blockers on one side. The ARBs, they cause decrease in fibrinolysis, mononuclear cell migration, the collagen matrix formation, endothelial function, plaque stability, and arterial compliance. So everything is affected favorably by using or by the use of ACE inhibitors and ARBs. Whereas the calcium channel blockers have their own advantages, they increase the nitrous oxide production, then the matrix metalloproteinases activity and the cholesterol deposition in the membranes is affected favorably by using CCBs. Whereas both these used together can give rise to decrease in oxidative state, stress, platelet aggregation, inflammation is decreased, and the smooth muscle cells proliferation, vascular proliferation is also decreased. We know that the modifiable risk factors are hypertension, albuminuria, the renin-angiotensin system, the dyslipidemia, anemia, smoking, glycemia, calcium phosphorus product, and others. These are the main things, of which the angiotensin system, angiotensin 2 can be called as cardiac and renal toxin. The angiotensin, as we all know, gets converted to angiotensin 1 and then angiotensin 2. So this is done by renin, and this renin can be inhibited by drugs like the inhibitors. You have drugs which inhibits renin directly here, or you have drugs which have an effect on the ACE, that is the angiotensin converting enzyme. And then we have some drugs which affect the AT receptor here, AT1 receptors, which leads to the receptors. They can cause the increase in aldosterone, the increase in the reactive oxygen species, increase in the cell growth, and sympathetic activation. So everything can be counteracted by using ARBs. Interaction between the RAS and the central nervous system, which the sympathetic nervous system, is that by using an angiotensin inhibitor, we know that renin production can be blocked by using the angiotensin, or renin production will act on the brain and through the angiotensin 2, and then the brain will activate the sympathetic nervous system, which will act on the kidney again. So the use of these angiotensin inhibitor, these blockers, or the renal sympathetic nerves also can be blocked. So recently you will also come to know that a new approach to hypertension will be the denervation of the kidney. The sympathetic nerves can be denervated. So a new procedure which has come up and which will be a tool for the cardiologists now. The RAS modulators, we know that angiotensinogen conversion to angiotensin can be done by drugs like aliscrenin. The angiotensin 1 to angiotensin 2 conversion can be blocked by the prils, that is the ramipril, the other prils, enalaprils, and the ARBs which block the conversion of angiotensin 1 and they block the receptors there. So all these sartans, they are useful here, and all the four things which I have told, they can be blocked. So the ARBs were developed, and we know that the first ARB was losartan, then came valsartan, candesartan, irbesartan, then came telmisartan, and finally came olmesartan, which came in the way back in 1995. And we have a lot of papers on olmesartan now, and the beauty of olmesartan is that it acts on variety of things besides hypertension. So look at this paper, American Journal of American College of Cardiology. Olmesartan, but not amlodipine, improves endothelium dependent coronary dilatation in hypertensive patient. This is another paper which says that medical treatment of Marfan syndrome, time for change. You will be surprised that people have sort of introduced this gene of Marfan syndrome gene into mice, and they have produced mice who have Marfan syndrome. And these mice also developed aortic aneurysm, and the development of aortic aneurysm was prevented by feeding these mice with losartan. So that is how the ACE inhibitor, the ARBs have been found to be very useful in the management of Marfan syndrome. Recent advances in understanding Marfan syndrome, should we now treat the surgical patients with losartan? So losartan has been found to be very useful. Losartan in Marfan syndrome beyond blood pressure lowering. So it has effects which are much more than just a blood pressure control. This is another report which shows that effects of olmesartan on endothelial function. This is another paper which shows impact of olmesartan on progression of coronary atherosclerosis. So inappropriate activation of the RAS leads to hypertension, leads to diabetes, leads to obesity, heart failure, renal diseases, and metabolic syndrome. Actually, metabolic syndrome should be here. So the first thing is metabolic syndrome. Everything comes afterwards. So therefore, olmesartan or basically all sartans are useful in all these indications. So that is the beauty of this particular molecule, about which we are going to learn more from two stalwarts in the area. One is Dr. Brian, who is going to speak to us. But before that, Dr. Sanjay Agarwal, who is another friend of mine, he is going to speak to us for a few minutes. To introduce, I'll also take this opportunity to introduce to you Dr. Sanjay Agarwal, who has been practicing for last 25 years and who is the head of the Department of Medicine in Ruby Hall, also practicing at Jahangir Nursing Home as a very good clinician, very much interested in CMAs and arranging CMAs. I have always appreciated his organizational skills about arranging CMAs. So I request Dr. Sanjay Agarwal to come over and deliver his lecture. Thank you.
Good evening, ladies and gentlemen, and I would like to thank the organizers, Ranbaxy CVK, for inviting me for this lecture, and I would like to thank also Dr. Suresh Shinde for his kind words. I would also like to apologize for my bad voice. I have a very bad throat, so probably you'll have to bear up with me. Now, I'm going to take this forwards from where Dr. Shinde left. He kind of introduced the physiology of hypertension, and I'm going to sort of look at a real case scenario which of a patient who comes to your clinic, and how would you take decisions, and probably set the stage for Dr. Brian to introduce the molecule, discuss the various trials and the benefits of the molecules. So let's look at a typical case which would come to our clinic. Name S.A., 49 years old. He has a history of diabetes for 9 years, has a history of hypertension for 6 years, is obese, has a migraine, has occasional headaches, giddiness, and does feel dyspnea on effort. On examination, his BMI is 32, his pressures are 160/90, has a mild pedal edema, his systemic examination is normal. On lab values, his A1C is 7.4, has a protein excretion of about 1.2 grams, fasting glucose is 110, post-meal is 180, has a urea of 42, and a creat of 1. So this is what we would really see in a day-to-day practice, somebody who's got a mild hypertension, mild deranged blood sugars, normal renal functions, but needs a further tightening of his blood pressure control. And what is this going to translate into terms of benefits is what I'm going to really look at in a couple of slides. And his current medications are glimepiride, metformin, and metoprolol. So this is the typical case that we would be seeing. Now there are three sort of questions that we really need to look at. What is the impact of uncontrolled hypertension in a diabetic patient? So why should we really be looking at stringent control of his blood pressure, and what is going to translate in terms of benefits? What should be the current target blood pressure that we should be aiming for these patients? And should it be individualized, or should we really follow the guidelines? And which antihypertensive agents are recommended for patients with diabetes? So what would be the optimum treatment that this patient would need? So let's start with the first one. What is the impact of uncontrolled hypertension in a